Thank you to all of you who are here on what I understand is midwinter ski break for Seattle Public Schools. I don't know. Okay, so hence the fact that a lot of our faculty are not here. But I'm very pleased and excited to present our fourth year fellow to give grand rounds today, Dr. Jovana Martin. So Jovana came to us from doing college at Emory, doing her medical school at Case Western Reserve, and then did residency at University of Alabama. When she came to interview with us, she was one of our most highest ranked applicants. We were all incredibly impressed by her, and she has far exceeded all of our expectations. During her first 2 years of research, Jovana got her MPH here at the University of Washington and did her thesis research on the disparities in preventative services for survivors of endometrial cancer. She will be, this next coming academic year, joining the Women's Cancer Care Associates in New York, and we're very proud of her. So I'd like to welcome Dr. Martin.
Thank you, Dr. Urban. Good morning, everyone. So today I'll be talking about post-treatment issues in GYN cancers, including survivorship care, also perceptions, approach, and things for the future. I don't have any disclosures. So the objectives of this talk will be to review the trends in increasing prevalence of cancer survivors over time, to review the surveillance methods for gynecological cancers, and to understand the late effects of cancer treatment. A cancer survivor refers to any person who's been diagnosed with cancer from the time of diagnosis until the end of life. Care in the survivorship period is often focused on the time of cancer-free survival. The Institute of Medicine put forth recommendations in a report From Cancer Patient to Cancer Survivor that survivorship be recognized as a distinct phase of cancer care. Survivors who have completed primary treatment should be provided with a comprehensive care summary. They also recommend that providers use evidence-based guidelines and screening tools to detect and manage the late effects of cancer treatment. In the U.S., there are currently over 15 million cancer survivors. Improved screening, early diagnosis, advanced treatment methods, and an aging population are the key contributors that have led to a steady increase in the number of individuals living with cancer. The most common female cancers include breast, uterine, colon, thyroid. And by 2026, the proportion of women with gynecological cancers will also increase, with an anticipated rise in uterine cancers by 200,000, 4,000 in cervical cancers, and 50,000 in ovarian cancers. So this table shows the number and percentage of cancer survivors in categories based on the number of years since diagnosis. And the first column is the years of diagnosis in categories, so first 0 to 5 years, and then 5 to 10 years, and so on, and then a number in each category, and then a percent. And then in the last category or column is the cumulative percent, so this adds up to 100. So the main point from this slide is to understand that the majority of cancer survivors are actually living longer than 5 years, with over 70% of survivors being diagnosed over 5 years ago. This table has a similar layout, with the purpose being now looking at the prevalence of U.S. female cancer survivors by age, with age in this column. And here we can see that more than 50% of cancer survivors are over the age of 60 that are living with cancer in the U.S. So what's the problem here? So while the cancer population is aging and living longer due to an aging and growing population, improvement in cancer survival rates, the demand for oncology services is also rising. During that same time, the supply of services provided by oncologists will continue to grow more slowly than the rate of demand. There's an expected shortage of oncologists by 2,550 to 4,000 by nationwide by 2020. The growing number of cancer survivors combined with a shortage of oncology specialists will require greater coordination of survivorship care between oncologists and primary care physicians. The intersection of views between provider types is not clear. In a qualitative study, oncologists were not likely to have confidence in primary care physicians to perform appropriate tests for cancer. They also did not have confidence in primary care physicians to perform the appropriate management for the late effects of cancer treatments. In the same study, primary care physicians themselves felt that they didn't have confidence in their own skills to perform testing for the management of recurrent disease or for the late effects of chemotherapy, and that was upwards of 40%, as seen in this bar diagram here. It was a systematic review. It included 35 studies with over 10,000 primary care physicians. The majority of primary care physicians desired involvement in all aspects of cancer care, and 95% of those providers preferred an active role in the role of the cancer survivor. They would like to have been involved in the management of pain, the emotional support of the patient, as well as symptom management. They also mentioned that they would have liked to be involved in the comorbid conditions as well as monitoring for recurrence. There was another systematic review that examined the relationship of communication between primary care providers and cancer specialists regarding the cancer survivor. They found throughout the studies that they reviewed that there were overall 6 themes. That there were poor communication between primary care providers and cancer specialists. Oncologists mainly endorsed a specialist-based model of care for cancer survivors. Primary care's physicians believe that they should play an important role in the cancer continuum. Primary care physicians were willing to participate in the cancer care continuum. Oncologists and primary care physicians were uncertain about the primary care physician's role in oncology expertise as well as oncology knowledge. There were discrepancies between primary care physicians and cancer specialists regarding these roles. Overall, cancer survivors in the survivorship period need surveillance for recurrent cancer, monitoring for late effects of cancer, and management of comorbid conditions and prevention care. Endometrial cancer is the most common gynecological cancer, with 61,000 incident cases yearly. The majority of cases present with localized disease and have a favorable prognosis, with 83% of women alive at 5 years. 80% of endometrial cancers are type 1 due to unopposed estrogen. Many of these women have a high prevalence of obesity and other medical comorbidities. And other work has shown that women with endometrial cancer have a higher risk of death from cardiovascular disease than from endometrial cancer. The mainstay for treatment for endometrial cancer is a hysterectomy. Women with low-risk endometrial cancer have a lower risk for recurrence and generally do not require treatment after a hysterectomy. Women with an invasive endometrial cancer are considered intermediate risk for recurrence, and criteria such as those put forth by GOG 99, which takes into consideration a combination of age and the presence of lymphovascular space invasion, grade 2 or 3 histology, outer third myometrial invasion, can be used to determine if women need more treatment, generally with radiation, but potentially with a combination of chemotherapy and radiation. Women who have positive lymph nodes or serous histology are considered to be high risk and are generally treated with chemotherapy, but again, there could be the addition of radiotherapy. The majority of recurrences occur within 3 years of treatment. Women with early stage endometrial cancer have a 2 to 15% risk of recurrence, while women with advanced endometrial cancers have a greater than 50% chance of recurrence. Approximately 70% of women are symptomatic at the time of their recurrence, with the most common symptom being vaginal bleeding. The most common sites of recurrence are in the vagina, followed by the pelvis, or distant metastases in the abdomen or lungs. The NCCN and SGO have both published guidelines on the surveillance of gynecological cancers. To date, there have not been any prospective trials on the best management strategies for the surveillance of endometrial cancers. But given that the majority of recurrences are symptomatic, Surveillance with physical exam alone can detect up to 70% of recurrences. The physical exam, when performed, should be comprehensive and include a thorough pelvic exam along with a speculum exam and rectovaginal exam. The detection rate for recurrences is improved if the review of systems is included with the exam. When performing the review of systems, you want to be sure to include questions regarding vaginal bleeding, discharge, change in bowel habits, or bladder habits. The physical exam review system should be performed every 3 months for 2 years, and then every 6 months following, and then can be spaced out to yearly after 2 years. Routine measurements of CA-125 are not recommended unless it was elevated at the time of diagnosis. Vaginal cytology does not offer improved detection for cancer recurrence over physical exam. Often cytology has atypical cells with a high false positive rates leading to increased testing and expensive care. Imaging studies such as a chest CT scan or abdominal pelvic CT scan, including an MRI, can be performed for patients who are symptomatic or have abnormal findings on a physical exam. So cervical cancer in the US has approximately 12,000 incident cases annually. Approximately 50% of cervical cancer cases are diagnosed at stage 1, and the 5-year survival rates for early stage cervical cancer are in upwards of 90%. The majority of cervical cancer recurrences occur within the first 3 years after diagnosis. And again, similar with endometrial cancer, symptoms are common with either pain, potentially lymphedema that is new at onset, vaginal bleeding, discharge, or if there are pulmonary metastases, a cough. Additionally, there can be weight loss. Guidelines from NCCN and SGO similarly recommend surveillance with a physical exam or review of systems initially at 3 months in the first 2 years, which can be spaced out after 2 years and then spaced out to yearly after 5 years. Cytology is not recommended, particularly if there's a history of radiation, given the increased rate of abnormal pap smear and ASCA cytology leading to more testing and increased costs. And then imaging is recommended if there are concerns or signs or symptoms of recurrence. Ovarian cancer in the US has an incident rate of 22,000 cases annually. Approximately 75% of those cases are diagnosed at advanced stages, and the 5-year survival rates are around 46%, with recurrences for early stage of about 25% and advanced stage at 80%. The majority of ovarian cancer recurrences will be with distant metastases in the abdomen, but 30% can be pelvic. The physical exam, including a pelvic exam, is able to detect a recurrence alone of approximately 60% of the time. Review of systems can detect or predict concerns for recurrence approximately 49% of the time. Imaging is recommended for ovarian cancer with concerns for findings on physical exam and/or review of systems. The CA-125 per guidelines is not recommended to be checked routinely. However, the majority of providers do check a CA-125 that is usually elevated at the time of diagnosis. Additionally, a CA-125 can be elevated approximately 2 to 5 months prior to signs of symptoms. For vulvar cancer, the incidence is approximately 6,000 cases per year with an annual incident death rate of 1,100. Treatment modalities can include a radical local excision plus or minus inguinal femoral lymphadenectomy. Within treatment modalities other than that, including chemotherapy, radiation for more advanced disease. The 5-year survival correlates with stage and lymph node status, with those who have negative nodes having a favorable prognosis with over 80% survival. The majority of recurrences occur within the first 2 years. However, there have been reports that recurrences can happen several years from the time of diagnosis up to 10. So therefore, these patients are recommended to have long-term surveillance. Review systems in addition to the physical exam is recommended during routine surveillance exams. During review systems, you would want to be assured to assess for leg, groin pain, changes in urinary symptoms, lymphedema, any weight loss or cough. And during a physical exam, careful inspection of the vulva, cervix, or perianal skin, as well as inguinal nodes. So there are many late effects of treatment, but a few can range in the spectrum of psychosocial, sexual dysfunction, or lymphedema. So patients with cancer are at increased risk for psychiatric disorders, including depression, anxiety, substance abuse, and stress. A population-based matched cohort study that included over 300,000 cancer patients found that among individuals with cancer, mental disorders peaked within the first week after diagnosis and remained elevated for 10 years after diagnosis. Additionally, compared with cancer-free individuals, there was an increased use of psychiatric medications at 3 months after diagnosis. There was a survey done by the Livestrong organization where over 93% of cancer survivors indicated that they had experienced one or more emotional concerns. The three most frequently selected areas were for fear of recurrence, sadness or depression, or grief and identity problems. Despite a high number of emotional concerns reported by the cancer survivors in the Livestrong survey, the majority of individuals reported that they did not receive care that addressed these emotional concerns. And you can see that in this figure here, as in the yellow, this represents a portion of patients who in this previous figure reported those emotional concerns did not receive care, and in the gray, those that received care. There are recommendations made by NCCN that recommend that providers monitor for distress at times of transition in care and surveillance. They screen for depression and anxiety and recognize that the fear of recurrence felt by the cancer survivor is an emotion that can lead to increased anxiety among cancer survivors and represent and contribute to potential symptoms and part of the situation during the medical visit. In the general population, up to 40% of women have sexual complaints. Sexual dysfunction can affect women with any type of cancer, and sexual dysfunction is prevalent amongst 50 to 90% of gynecological cancer survivors. Dyspareunia accounts for 20 to 50% of the dysfunction seen among cancer survivors, with low libido accounting for 40%. Modalities used to treat cancer that affect sexual function can include surgery, which can distort anatomy, particularly with a radical hysterectomy or vulvectomy or vaginectomy that may shorten the vagina. Additionally, chemotherapy or radiation can lead to vaginal mucosal alterations. The cancer diagnosis itself can result in body image alterations for survivors. This often impacts a patient's concept of attractiveness or identity as a sexual person. Another key factor in sexual function is relationship issues. For women with a partner at the time of a cancer diagnosis, the treatment process may result in stress or shift in relationships where partners become caregivers, the caregiver role that lacks a prior sexual dynamic, or the caregiver may fear that sexual activity will hurt the patient. Patients may have sexual complaints, but may not bring them up to their providers. It has been reported in the literature that up to 50% of survivors have experienced at least one sexual problem during their care, but only 19% attempted to seek medical help. Barriers to screening for sexual issues include limited time with the oncologist, having many of the high priority issues to discuss, and lack of comfort and training with these issues. A useful approach is to routinely ask patients a few questions during the medical visit or to use a brief sexual symptom checklist. If sexual dysfunction is identified, then workup with a history and physical exam and labs should be done if appropriate. Vaginal atrophy can result from hypoestrogenism, and atrophy can also be the most common etiology of dyspareunia in cancer survivors. Vulvovaginal atrophy is characterized by dryness, thinning of the epithelial lining, and inflammation. And this can result in loss of lubrication and elasticity, which, along with thinning of the epithelium, can result in sexual dysfunction. Dyspareunia is an important quality of life issue and the most common sexual complaint among female cancer survivors. Water-based or silicone-based lubricants are the first-line treatment for vaginal atrophy. One consideration for such a lubricant is Replens. Vitamin E can also be beneficial. And then vaginal estrogen does improve the elasticity of the vaginal epithelium and can be considered in certain individuals. Vaginal stenosis is a severe complication that affects many women who are treated with pelvic radiotherapy. Radiation may result in radiation vaginitis or vaginal fibrosis with possible vaginal shortening or stenosis. The development of radiation fibrosis is the result of damage to the vaginal mucosa and associated blood vessels and connective tissues. Patients should be counseled regarding the risk of vaginal fibrosis following pelvic radiation and provide instructions on the use of a vaginal dilator. Fibrosis is considered to be a late effect of radiation therapy, so therefore, during medical visits, providers should continually assess the further vaginal stenosis and the use of vaginal dilators during each visit. So another late effect is lymphedema. And lymphedema can occur when lymph fluid accumulates in the interstitial tissue, causing swelling. Lymphatic dysfunction is generally graded in grades. Stage 0 is considered to be subclinical, but stage 1 is considered to be accumulation of fluid characterized by pitting, edema. The swelling can be relieved with elevation in stage 1 and is considered to be reversible. In stage 2, the clinical syndrome, unfortunately, is considered to be irreversible, and therefore it is recommended that providers continually assess for lymphedema before there is a progression in stage 2. In stage 2, some of the symptoms can be, for lymphedema noted, will be spongy tissue, as well as pitting edema that becomes less evident as the swelling increases. There also can be tissue fibrosis present that causes hardness and an increase in size of the extremities involved. In stage 3, there often can be debilitating swelling as well as skin changes, including a severe dry, scaly rash. Cancer-associated lymphedema occurs due to lymphatic dissection at the time of surgery. Risk factors for increased lymphedema include obesity with a BMI greater than 30, the presence greater than 30, infection, and also the increased number of nodal bundles that are removed. Lymphedema can also be caused due to obstruction related to tumor or tumor infiltration of the lymphatic channel by the tumor. Radiation can destroy lymphatic channels. Additionally, up to 20% of patients with gynecological malignancies can experience lymphedema at some course during their treatment. It's recommended that providers inquire about symptoms at each visit related to lymphedema, determine the frequency and severity of swelling, as well as the quality of life issues related to any swelling the patient is experiencing. Because lymphedema can be a sign of recurrent cancer, it is recommended that providers rule out the recurrence of cancer at the same time. If available, the patient can be referred to a lymphedema therapist or recommended to use compression garments, and the providers can provide education and self-care management to the patient. Additionally, patients with lymphedema are at higher risk for localized infection, including lymphangitis, which may require IV antibiotics for treatment. Additionally, the survivor needs assessment in terms of management of comorbidities and preventive care. Providers caring for cancer survivors should monitor for and appropriately manage comorbid medical conditions that were present either prior to or cancer treatment or developed post-treatment. It is estimated that up to 55% of cancer patients have medical comorbidities. The comorbidities are more related to age than due to the cancer itself. NCCN recommends that survivors are encouraged to achieve and maintain a healthy lifestyle with diet that is high in vegetables and whole grains as well as fruits. They also recommend the patients engage in moderate physical activity for at least 150 minutes per week. Recommendations are also for maintaining a healthy body weight and minimizing obesity, which for certain disease sites can prove beneficial in terms of preventing recurrence and providing health. Additionally, patients with cancer and all patients should, if they smoke, quit tobacco, minimize alcohol, practice sun safety, and follow up with their primary care physician for age-appropriate health screening and preventive measures. The prevalence of cancer survivors is increasing. The multimodal approach to cancer care can lead to the late effects and symptoms of treatment. Cancer care in the spectrum of primary care and specialty care have a role in the care of the survivor. These are my siblings and my dad. Thank you. Yes. Mm-hmm. Mm-hmm. Yeah, so that's a great question. And she was talking to Dr. Irvin somewhat about that. So you're right. There are, so just for the general audience, there are survivorship clinics that may include mid-level providers. The patients can go after they've reached a certain point in their treatment for their cancer, they finish treatment, and they probably felt to be more in the lower risk for recurrence. Their primary oncologist is not as worried about them. I think those clinics provide a lot of resources. But a lot of the models for survivorship care that at least are being published on and being advertised more include a lot of integration and crosstalk between physicians from different disciplines, so including oncologists, other specialty oncology providers, and primary care physicians to provide the overall medical care for the physician. Mm-hmm. Mm-hmm. Yeah. That's a great question. So, well, number one, there's no prospective data guiding the management of vaginal estrogen, but we do know it's estrogen. Some of our cancers have estrogen receptors or hormonally responsive. Um, so we can go by disease site. So for ovarian cancer patients, um, if they have signs of vaginal atrophy, dryness, it's affecting their sexual dysfunction or even incontinence related to that, using a course of vaginal estrogen is generally considered to be acceptable. It's not something that we would prescribe to every woman who is postmenopausal and has a history of ovarian cancer, but in cases where it's needed and other methods have not worked. Um, My attendants can chime in here too because I'm not in practice yet. So for uterine cancer, so let's just say like an endometrioid, which is more run of the mill with estrogen and progesterone receptors. Um, Again, there's no data against it, but some may take pause because of the more hormonally receptive nature of those tumors and the fact that they are more likely to recur in the vagina.